good morning everybody. In the next few minutes I would like to introduce you my research topic and my progress about the COVID-19 associated multisystem inflammatory syndrome. My name is Adrienn Lukács and I'm a junior investigator in the program of Translational medicine. I'm a physiotherapist and during the next years my mission is gonna be to improve the pediatric physiotherapeutic care. To reach this goal with my researches, I would like to provide scientific and profession-specific information. We are conducting 3 different studies focusing on the main parts of the MISC. The first one is about the characteristics and prevalence of the cardiovascular abnormalities. You can see our analysis is still ongoing because we have a lot of outcomes and our targeted journal is the JAMA Pediatrics. 3 to 6 weeks after COVID-19 infection, children can develop a multisystem inflammatory syndrome. For a million of SARS-CoV-2 infections, its incidence is around 300. The main problem with this disease is that more than 75% of these children will experience some kind of cardiovascular involvement during their disease course. Luckily, in most cases, these changes are normalized at discharge, but sometimes they can remain and become long-term morbidities. As a physiotherapist, it is really important to know whether if we should expect any kind of cardiovascular problem or not, because it can influence the whole rehabilitation process. We are looking for those children and adolescents who are under the age of 21 with active MISC. We conducted a systematic search with the search key and got overall 196 eligible full text. We have a huge number of outcomes, as I mentioned before, including radiological and ECG findings, laboratory parameters, and intensive therapy approaches. I would like to present you my latest 3 outcomes. The first one is the ECMO support, which is a cardiac and respiratory support in the severe cases. We included 51 articles, and for almost 7,000 patients, we got an overall incidence around 2% each. We have 4 subgroups based on the population type and based on the number of centrums. In case of the A and B subgroups, we included general population, means of those who were admitted to a general ward or then followed to the ICU, but their data is mixed. The only difference between them is the number of centrums. In the case of the C and D subgroups, we included only those children who were in severe conditions, meaning only those who were admitted to an ICU or who developed serious complications, for example, acute kidney injury, acute heart failure, or who were deceased during their hospitalization. You can see higher rates in the C and D groups in addition for the severe cases. The second outcome is the incidence of cardiomegaly, which somehow can't be visible there, but I can summarize it quickly. So we included 13 articles, and for almost 300 patients, we got an overall incidence about 16% each. We followed the same 4 subgroup system, and the heterogeneity was 78% if I remember well. The results follow the same we could see worse results in the severe groups. And the last outcome is the level of troponin T. We also included 13 papers in it, and for more than 300 patients, we got an overall mean value about 48.0 nanogram per liters, which is more than 3 times higher than the normal cutoff values. We should expect an increased probability of myocardial damage over the 14 nanogram per liters cutoff point. The heterogeneity was 84%, and we also went from the general population to the more severe cases, and you can see there was a higher amount of troponin T in the most severe subgroups. So, as the others said, we also have some strengths and limitations. We included a high number of outcomes, and therefore these outcomes are covering the most important parts of the disease spectrum. We also have a high number of studies, so we are able to form different subgroups to analyze. We have some limitations. MISC is very new, therefore we had to include different study types, and the articles used at least 3 different diagnostic guidelines and different outcome definitions, so this made our population heterogeneous. As a final conclusion, we can say that children with MISC can present a broad range of cardiac findings. Therefore, cardiac monitoring is essential in all cases of these children. And our findings are in agreement with the ACR's recommendations too. We also say that further investigations are needed to determine more associations and causal relationships on this topic. As an implication for practice, the incidence of cardiomegaly and other cardiac complications are high. Therefore, we suggest an early cardiology consultation in every case. And troponin T changes are also relevant, and in cases with abnormal values, it should be regularly monitored until normalization. As an implication for research, consensus is needed about the short and long-term data collection, meaning the timing, the used criteria, and the methods. We also need further investigations to find laboratory and imaging factors which can predict the severity of this disease. Our second study is a cohort analysis about 45 previously MISC diagnosed children. We know that the bedridden periods and mechanical ventilations are serious complications of the intensive care unit treatments, and in case of the MISC children, more than 60% of them will need an admission to an ICU during their disease course. Therefore, our aim is to compare general population's data with those children who were 1 year ago diagnosed and cured with MISC. MISC registry was established in 2020 by the Center for Translational Medicine and contains data from the Hungarian National Pediatric Institute. We would like to assess the first 45 children's data after finishing their physiotherapeutic assessment. We are now completed with 32 patients' data. The registry has an ethical approval, and we are conducting non-invasive standard physiotherapeutic tests, part of it. We included those children who were hospitalized in the Hungarian Pediatric Institute between October 2020 and May 2021 with the diagnosis of MISC based on the WHO criteria. And our last study is an international multi-center survey investigating the knowledge and experience level of the physiotherapists among the world. MISC is very new and unknown. Although it has some similarities with Kawasaki disease and toxic shock syndrome, we are currently in the phase of uncertainty. And that's the reason why we would like to assess and find the similarities and discrepancies among hospitals to tell our colleagues what the others do and why do it. We changed the platform and moved from Google Form to the RedCap system, which is a much more research-friendlier online database, and now we are adapting our questions to this platform. And as an overview, you can see the planned submission dates to our project, and also with the results of our researches, we can comprehensively assess when and how can a physiotherapist help to these children, and with this information, we can efficiently standardize the treatment options. The man who moves a mountain begins by carrying away small stones. It's from Confucius. Thank you very much for your attention, and please feel free to ask if you have any questions.
I would like to ask you, in connection with your survey, that how are you planning to reach these physiotherapists internationally?
Oh, thank you very much your question. We think about a lot this, and now we would like to directly get in contact with the Hungarian Physiotherapy Association and also with the APTA, which is the American Physiotherapy Associations. And I also would like to involve some other media platforms like the Physiopedia, which is a webpage in our scientific world, and also the Physiogram, which is a kind of page in the Instagram media. So that's the plan, and we would like to ask them to promote our data collection.
I would like to ask that when defining the population in your first project, you have said, I think, you set the age boundary at 21 years. Was there a special reason for that? And do you plan to do subgroup analyzing on the age groups?
Thank you very much for your question. Yeah, this was for a reason. We wanted to include researches from the United States. The American CDC set up these diagnostic criteria for the 21 age limit. In contrast, the British Royal group made 18 years, and the WHO group 19 years old criteria. So that's the reason why we kept the 21 years age limit. Thank you. And yes, sorry. So we would like to make subgroup analyses. Our first intention, based on the publicated researches, was that to make 3 subgroups, 0 from 5 years, 6 to 10 years, and over 11 years. That's the plan.
I would like to ask is regarding to your second project. When do you plan to finish the assessment of the children? And just briefly, what is your personal experience with them already?
Thank you for your question. We plan to finalize all of the assessments until the middle of summer, but it highly depends on the medical staff's schedule. Also, we are just a part, our examination and assessment is just a part of a complex medical examination, including hematologic and cardiac evaluation too. My experience is that the MIST children physical status is around the general level, or maybe a little lower than it, because we have a heterogeneous population, including children with cerebral palsy or those who have a high weight changes in relation with the used medications, for example, steroids. So that's.
Firstly, I really want to emphasize how amazed I am, like when you are performing as a physiotherapist and dealing with high level of medical questions. So this is really great. And my question would be that how can your first results from your meta-analysis change the plans in the treatment in your area?
Thank you very much for your question. In general, children, in MIST, one of the most acute problems is the reduced level of left ventricular ejection fraction. And in case of these children, their exercise tolerance is impaired, and also they complain earlier fatigue and dyspnea during their physical load. So we have to build up step by step an adequate rehabilitation process, and we have to make it in a longer period adapted for them.